Yes. That's okay. Got it. It's done. And then again, you'll be again the host, Dr. Sulafa.
Okay. Are you hearing me, Dr. President Jalila?
Yes.
Okay. Should we start now?
Yes, please.
Okay.
Fine.
Okay. Hello, ladies. I would like to introduce myself. I'm Dr. Sulafa Abdullah from Sudan, and I will be the moderator for this webinar. And I'm welcoming all of you to this cervical cancer elimination webinar organized by CIAF. And it's my honor to be the moderator for this important gathering, where we have come together to address a critical issue that affects the lives of women around the world, and especially in Africa. And as we know, cervical cancer remains a significant global health challenge, causing suffering and loss of life for high number of women. And according to the last estimates and figures of statistics, maybe less than 2 minutes a woman die from cervical cancer in Africa. So, and this is not the accurate number. Now, recently they saying maybe every seconds, not a minute. So, however, through this our movement in CIAF, we have the opportunity to unite, to share our knowledge, to work towards a future where cervical cancer, we hope, to be a past in Africa. And as we know that Soroptomis International is committed to empowering women and girls. So we have to advocate for this issue, and stockholders should be engaged with us in order to succeed in the elimination of this disease. It needs a lot of efforts, a lot of activities, because it mainly affects women. We know it's a cause of death for women. And today the webinar will be presented by Dr. Amira. Really, she is a leader for this disease in Sudan, and she is an expert in this work, in research, in her daily practice, and we as I said, we have to work more, to collaborate, to inspire each other to take concrete steps towards cervical cancer elimination. So we have to work together. And Soroptomist, it's really a unique type of organization. We are as a clubs in different parts in our continent. We are now, I think we are easily communicated, and so we can make a profound difference in the disease in Africa. So welcome all. And now, Dr. Amira, you can start your presentation.
Hi. Greeting to everybody. I'm Dr. Amira Burhan, a consultant gynecologist from Sohba University Hospital, Khartoum, Sudan, and Soroptomist International Khartoum Club. I will share my... Can you share, please, Dr. Sulafa? I send it to your email, or you can allow me to share it. Can you allow my sharing?
Yes.
Dr. Amira?
I send
Now
it to your email.
No, you can share it now.
I can share?
Yeah.
Yes. Can you see my presentation?
Yeah.
It's a PowerPoint.
Yeah.
It is showing your desktop.
Yeah,
Yes.
not yet your
Not
presentation.
yet. Yeah, pick this presentation if it's the first one. Yeah, that one.
Now?
Click on it to open.
Double click.
You
Double
can
click.
also go back and open it first, and then you share it as a window.
Sorry. 1 minute.
هو ما تبدا تتوجعي ليا.
Isn't it shared?
Not yet. Dr. Zulafa. Oh, that's okay.
Yeah.
Yeah, that's great.
Perfect.
Yeah.
Is it okay now?
Yes.
Yeah.
Yeah.
See, I'm happy to talk to you today on this special day, 17 November, which is the Cervical Cancer Elimination Day of Action for Africa. And we as Seroptomists, we are committed to support women and stand for their interest and for their problems. It is stated that more than 300 women in Africa hear the word "you have cervical cancer" each day. And we are committed to make this number into zero by making them getting informed, screened, and vaccinated. Cervical cancer is a major burden with complex social and economic effect on women, on their families, and on the children they leave behind. There is experience from international efforts that have led to a major improvement in maternal health outcomes, and a similar global drive is urgently needed. WHO have launched the global strategy to accelerate cervical cancer, and they on 2020, the same day, 3 days ago, and that was depending on 3 main pillars. That 90% of the girls should be fully vaccinated with HPV vaccine. 70% of women should be screened at a high performance test by the age of 35 and the age of 45 another time. And 90% of women identified with cervical disease should be treated, either that is pre-invasive or invasive cancer. And this, if this tract is on by 2030, we will be on the track to eliminate cervical cancer in this century. Cervical cancer is actually a rare disease in high-income countries, and more than 85% of new cases and 90% of mortalities are in the low-income countries. It has the most striking inequality in the global situation. Africa has been the most severely impacted by this. If you can see this graph, my voice is clear, please. Can you hear me?
Yes.
Yes.
So from this graph, we can see how is the different, this one is the dark brown is the incidence and the light brown is the mortality from the disease. You can see that some countries have very high, equal to 10 times of the high income countries. And if you notice to these countries, you can see that by region, in Eastern Africa, Southern Africa, Western Africa, Middle Africa, and Northern Africa, all within the countries with high incidence of cervical cancer and high mortality also. So cervical cancer ranks the fourth cancer affecting women worldwide, and it ranks the second most diagnosed in Africa. Cervical cancer is the second leading cause of cancer deaths in Africa, and around 117,000 women were diagnosed with cervical cancer in 2020, and 321 women heard the word, "You have cervical cancer," each day. And the 10 most common countries with high incidence of cervical cancer, all are in Africa, or most of them, or 19 of them are from Africa. So if you can notice this map, the darkest color is the higher incidence, that is more than 19 per 100 woman years, and it concentrates mainly, the color concentrates mainly in Africa, which makes it clear that most of the cases of cervical cancer actually are in Africa. In Africa, cervical cancer is not only common, but there is actually no accurate estimate of the disease prevalence in many countries. Screening and vaccination programs in many countries are non-existent, and most patients present very late, have never heard of cervical cancer before diagnosis, and many patients never reach medical service. They die unnoticed, and they die in pain and misery. Other facts about cervical cancer that is mostly asymptomatic in its early stages. That's why 80% of cases present at an advanced incurable stage. And it is an important cause of mortality in relatively young women, not like other cancers. It affects 40 to 50 age group. And the cause of cervical cancer is well known and well studied to us. And there are proven approaches for primary and secondary prevention for the disease. There are effective, affordable, cost-effective, and life-saving interventions. With these facts and the prevalence to be very high in Africa like this, it really needs in action. To have some little information, I will go fast on that, about the causation and the cervical cancer process of oncogenesis. That is the most important necessary cause for cervical cancer is persistent infection with human papillomavirus. It is the most necessary cause, and other factors that are involved in cervical cancer carcinogenesis are actually cofactors, or that surrogate or increase the incidence of cervical cancer or increase its persistence. So there is no cervical cancer without human papillomavirus. It is a DNA virus, double-stranded, that is actually looks like the coronavirus. It has more than 100 types, and many of them are enogenital. From those enogenital, there is 3 groups: oncogenic group, non-oncogenic group, and probably oncogenic, depending on the ability of the virus to cause cancer. And the most famous of these oncogenic group, or they're also called high-risk types, that is HPV type 16 and 18. This group includes around 15 types till now, and there are some of them which are probably oncogenic, but some viruses are non-oncogenic and they are not proved to cause cervical cancer, but they can cause genital wart like HPV type 6 and 11. Human papillomavirus does not cause cervical cancer only. It is a cause of other types of cancer. It affects the oropharyngeal and the genital area, and it can cause vulval cancer, vaginal cancer, anal cancer, and oropharyngeal cancer in women. And in men, it also causes oropharyngeal and anal and penile cancer. But in the case of the cervix, it cannot, there is no cervical cancer without human papillomavirus, and it is the cause of more than 70 or 80% of the cases are caused by type 16 and 18 only. The spread of human papillomavirus is either sexual contact or non-sexual also can be spread. Other risk factors that can be involved in cervical cancer, like age, that is because the process of oncogenesis, making the virus causing cervical cancer, it takes around 10 to 20 years. So it usually affects women at the age of 40s. Sexual debut at very young age, multiple sexual partners, which makes the liability of having HPV infection is more, and having many children, like multiparity, which make the cervix liable to have persistent infection. It is more in the low socioeconomic status and not being screened. Smoking also increase the cervical cancer incidence, and some infection like chlamydial infection and HIV. Actually, when you hear that cervical cancer is caused by human papillomavirus is a very common sexually transmitted disease. You have to also state that cervical cancer is not a sequelae, is a definite sequelae for HPV infection. It is a rare outcome of HPV infection because majority of infections clear in 1 to 2 years due to natural immunity. Only those who cannot clear the virus due to some problem in the immunity, due to smoking, or due to multiple infections, other infections, those are at high risk of developing cervical cancer. And the time lapse between HPV infection and the carcinogenesis is 10 years or more. This schematic diagram just shows how this process goes very slowly from normal epithelium of the cervix, with having normal cells. In this, the cells are having infection. The second group are having infection with cervical with HPV, but the infection here can be transient and it may regress. Here, the infection becomes persistent and it makes some change in the cells, and then the next step when the infection is persistent and causes change in many cells or most of the cells, more than 50% of the cells. And here, this is actually most of the cells are actually changed. We call this process is cervical intraepithelial neoplasia. That is, the disease is inside the cells, but it does not cross the basement membrane. When it crosses the membranes, then it invasive. Here, this is the invasive disease. The most important of this figure is that you can notice that the arrow of progression, and there is also regression process. At any time, they can be regression, but the regression is more in this early stage, and it is very less when it is advanced. And the progression is more when it is in the late stage. So this is the base for cervical screening that started by cytology so many years before that, more than 70 years. And it was basically to try to pick the process here in this line when it starts to be intraepithelial neoplasia with high risk for progression to cancer, and then to treat people in this area. Because if you treat them very early when they're just having the infection, this actually is self-limiting, and most of them will be cured. And as we said, it affects 80% of the population. So you need to treat many people unnecessary. So if you wait, and this process is around 10 to 20 years, it gives a very good time for screening to pick up the disease cells.
I think.
So from this information, when we know this information, and that, as we said, the human papillomavirus is a well-studied virus, and cervical cancer is a well-studied disease, and the causation is very established. So there is effective and evidence-based, cost-effective, life-saving intervention that can prevent cervical cancer in the form of vaccination and cervical screening. About vaccination, there are 3 types of vaccination. As we said, the human papillomavirus type 16 and 18 causes 70% of the cervical cancer. So the vaccine Cervarix, which targeted 16 and 18 types, it protects the woman from 70% of cervical cancer. The other Gardasil vaccine that have 4 components of HPV types, it again give protection against 70% only of cervical cancer, but it adds to it type 6 and 11, which causes the genital warts. So concerning cervical cancer, they have the 9 nanovalent vaccines also have
No, I think one of our sisters, she's not unmuted.
Professor. No, professor, muito manidi. The papa was a professor.
Baba,
Who's she?
Baba, please close your mic.
Thank you.
Thank you.
yes.
Mic is closed.
This is clear here in this screen also. They here, this is the Cervarix, only targeting 16 and 18. The Gardasil targeting 4 types of human papillomavirus. It protects 70% of cervical cancer, but in addition to it, genital warts is also protected. And here, if you have the nanovalent vaccine, you will add again type 31, 33, 45, 52, and 58. That's why if the prevalence of human papillomavirus is known in one country, and the data is already known, you can also identify which type of vaccine is more appropriate for that population. There is very important current new information that there is a move to a 1-dose schedule for routine adolescent HPV program vaccination. Actually, the vaccination program started by giving it to girls at the age of 10 years to 13 in 2 doses, in the 2 doses program. For the elderly or some young women at 20 years, then it should be given as 3 doses. Now it is proven that 1-dose schedule is also active, and it can do the job. So for low and middle income countries, a single-dose vaccine schedule could accelerate the introduction of HPV vaccine. It is important information that is which will make the delivery and the program cost simple and can better accommodated by lower income countries. Then we come to the prevention of cervical cancer through screening. As we said, that human papillomavirus is essential for the development of cervical cancer, and that human papillomavirus infection induces a precancerous lesion, which is called cervical intraepithelial neoplasia. And cervical cancer screening test can detect this CIN and then treat it by simple techniques without preventing its development into invasive cancer. So if we do systematic screening of the population, this can reduce the incidence. And this has happened in many high-income countries with a program that started so many years, and it succeeded to reduce the incidence of cervical cancer. But there are challenges of cytology-based screening programs in low resource setting because it is expensive test and it has to be repeated for many times. So this stimulated the research for alternative methods of screening. And when we come to the screening test, there are many of them, but they can be grouped into three groups. Through main group, the cytology-based screening, which is well known since before, and that is using either conventional screening or the liquid-based screening. The conventional screening is the Pap test, which is taking a sample or a smear from the cervix and spreading it into slides, and it is a lab-based test. The liquid-based cytology, it has some advantage upon the conventional screening by making the readability of the slide more efficient. Another group is visual techniques, which depend on actually examining the cervix using some liquids to see the change, and that is a point of care test that gives result at the same time, which is a very good advantage for low-income countries when the population, you might not get the referral system is not in place and the health system is not well working. There is also an HPV detection methods, which you can detect the human papilloma virus by detecting the DNA or the RNA of the virus. So if we want to do a cervical screening, we have to look for an accurate, easy to use test, and that is visible to perform in a particular setting, because if you don't have feasibility to perform the test, then you could not adopt it, provide result immediately, will make many advantage to the test, and it should be acceptable and inexpensive. The third pillar, now we have talked about the vaccination, which is the first pillar of the cervical cancer elimination by the WHO strategy, which was to vaccinate 90% of the girls less than 15 years. And the second pillar is to screen 70% of women. And the third one is to treat those who are affected by cervical disease, either affected by a pre-invasive disease or the invasive disease. So we can use the ablation or local excision for those who are having CIN2 or CIN3, which is pre-invasive. And we can use radical hysterectomy for those who have early stage disease, chemo or radiation combined. It is used for late stage disease, and when it is metastatic, and only chemotherapy is used for that. So when we come to our continent, Africa, why there is high incidence and mortality of cervical cancer? It's not because of it's not because of some racial factors or environmental factor. It is because of the lack of awareness among the population and the inaccessibility of the cervical screening and the cervical prevention and cervical treatment methods, so that makes the incidence in Africa very high. So the disease got undetected as it remains asymptomatic for a long time. And if the population are not aware about this disease, if there is no testing, so the disease goes beyond cure. It is not yet a priority in most of the countries because they have many competing priorities, and there is absence of good quality of screening and vaccination programs. There is limited access to early detection and treatment services, and there is lack of functional referral system. This means that action could be done to prevent this disease. So whenever you find a case of cervical cancer or a death due to cervical cancer, you should remember that this is unnecessary. This is a preventable condition, that this could be prevented. But because we did not do the action to prevent it, and we did not do the action to treat it early, that's why the woman dies. So it is somewhat because of non-action. So what we can do for that, what specifically can be done to change this facts and this high mortality rates and this high burden of the disease. It's important to increase the awareness of the community about cervical cancer, about the need to screen, about the need to vaccinate, and about the availability of the services if they are available, of course. And if they are not available, it is very important to increase their awareness, to increase the demand, and to make a case for convincing policymakers and funders to have this. The other thing is to increase the accessibility to cervical cancer prevention and treatment approaches, that is in the form of vaccination, in the form of screening, and the treatment of early and the treatment of precancerous cases. And this is very important also. Awareness is important in this condition also, to have the policymakers aware about the burden of this disease, about the preventability of this disease, and about the importance of having measures to prevent it so that it can be implemented. And it is important to train healthcare providers in different aspects of cervical cancer control. So for each pillar of the 3 pillars, you need to make good awareness. For example, for vaccination, you need to make good awareness for the population that the importance of this vaccine and its and the burden of cervical cancer. And it is very important to have the vaccine available and accessible to every girl, and to train the health providers on having this vaccine and giving the vaccine and keeping it in good condition and in transporting it and so on. Again, in the screening, the same.
يا أميرة برهان نتكلم عن السيرفايكال كانسر بريفنشن. أميرة برهان دي كانت نايمة معنا.
Sorry, doctor, please, could you mute your microphone?
Now, so what I was saying, that in the 3 pillars, even for the treatment, you need to have a trained personnel to do the treatment. You need to have the accessibility for this facility, and you need to make people aware that this treatment, if it is done early, it can cure cervical cancer. And we have to think of our role, that now we are informed on this disease, and we can act towards other women to raise their level of awareness and to change their behavior. So we need to have this information, to transmit this information to other people so that they can know, to transmit for the population, for the policymakers, and for those who can fund like these programs. But we have to ask ourselves, do yourself already had the screen for cervical cancer? Have you vaccinated your daughter against HPV? Are you really aware? If you are aware, if you are not aware, you cannot raise the awareness of others. If you are aware, you have to act first. If your answer is no, that means, would you expect your awareness program to succeed if they know that this fact? So it is very important, like this information is to change your own behavior, and then to try to transmit this information to others, making them changing also their behavior. So the important fact is you have to get informed, you need to get screened, and you need to get vaccinated. That is very important. The points to remember on this presentation, that cervical cancer represents a high burden on Africa with global disparity. Infection with high-risk human papillomavirus is a necessary cause of cervical cancer. Global drive is urgently needed to reduce the impact of cervical cancer, and that cancer control for women may be introduced through the new highly priority health and development goals. WHO released a statement that addressed the global inequity in women cancers and launched a global strategy to eliminate cervical cancer the public health problem, and that we need to understand our role. Thank you very much.
Thank you, Dr. Amira, for your highly informative presentation. And we have our Federation President, President Jalila.
Yes.
Yeah, President Jalila.
Yeah.
As regular, you should speak from the start, but I just jumped to Dr. Amira to show her presentation to us. So please, would like to hear from you about CF activities in regarding elimination of cervical cancer.
Okay, thank you. Thank you very much. I would like to welcome everyone in this webinar. Thank you for attending the webinar, our first webinar about cervical cancer. Soroptimis International is founded in 1921. It's a global volunteer movement with a network of approximately 66,000 clubs members in 120 countries. The vast majority of club members are women who have professional activities and who are also involved in social activities. Soroptimis International comprises 5 federations, among them our Africa Federation. Although the SI is a century-old organization, the SIAF is a new federation still under construction. The first African club was born in 1956 in Harare, Zimbabwe, and now in Africa, Soroptimis International exists in 5 regions, means 27 countries, and we have 114 clubs, which represent around 2,000 members. SI members work together to transform the lives of women and girls in distress. We help educate, empower, and enable opportunities for women and girls. The clubs work on many subjects, such as education, health, environment, empowerment of women and girls, etc. Since 2021, SIAF has been approached by sister of the Dubai Club, which is belonging to Soroptimis International of Europe, to partner with the Health for Life Funds, an United Nations agency, to work together towards the eradication of cervical cancer in Africa. We start our fundraising work last May with our international network and also with other partners. This work continues and we need funds to develop our action on the ground. Today, so we are organizing this webinar to mark our commitment to the fight against this disease. The United Nations has chosen the November 17 as a day of action against cervical cancer, and here we are with this presentation from Dr. Amira Burhan to discover and learn more about this disease. So thank you very much, Dr. Amira, for your agreement, and sorry you didn't have enough time to prepare this presentation, but it's very, very nice, and I congratulate you and thank you too much for this very good presentation. Thank you also, Dr. Sulafa, for moderating the webinar. And thank you to all participants for your presence today with SIAF. Thank you very much.
Thank you, President Jalila. And I see Al-IBB Connie, she's raising her hand. We can give her a chance to speak.
Yes, thank you very much. I was listening to Dr. Amira and I'm just you blew me away. If President Jalila agrees, we are going to have another webinar because we need to let Africa know what is happening in Africa, because we are dying and people don't know. So if you agree, because I'm putting you on the spot, we can arrange another webinar for the English speaking. And you know, President Jalila is nodding her head, which means it's a yes before you even say yes. Okay. My question, the only question that I have concerns the boy child, because there is screening, there is vaccination for the girl child. What about the boy child? I believe in the UK they are vaccinating both boys and girls. Please, can I have your comment?
Yes, thank you very much for this very good question. Actually, the vaccination started by girls because the vaccination industry and the delivery of the vaccine, it is very important to have it for girls first, because it affects girls very much. And the cervical cancer is having very high incidence. It also affects the boys, and it can cause, as we said in the presentation, that it causes many cancers for men. It is beneficial to have the vaccine, but in countries where there is no yet girls vaccinated, you cannot start with boys and girls, or that means you will delay the elimination of cervical cancer so many years. But in some countries, like in Australia, for example, they have vaccinated more than 90% of their girls. So they are now starting to vaccinate boys, and by near future, they will be having vaccinated all people, males and females. In this way, it can be an infection of the past. It can be like chicken and smallpox. It can be eradicated. So now WHO is talking about elimination of cervical cancer as a global health problem. That means reducing the incidence up to 4 in 100,000 women. But it is not in the form of eradication. It is a very long time process to have cervical cancer eradicated. So in our in countries like our area in Africa, we need to advocate for vaccinating girls. And we need to secure funds for vaccinating girls. When we have a good percentage of girls vaccinated, and we have a good community acceptance of the vaccine, then boys could be vaccinated also, because it is really beneficial for the boy, and it is beneficial for the girl also, because if the man is vaccinated and there is no virus, then transmission will not be there. So it will be also beneficial for cervical cancer. It is very important, but it is something like priorities only.
Mm-hmm.
I hope
the second question, you have answered it very well. The second question that I have, and this bothered me when I was doing that presentation in Dublin, it bothered me a lot, that Africa is so prevalent in Africa, and it's prevalent in lower income countries. Is there an explanation why the poor are attacked by that disease? Surely other continents do have multiple partners and you know all that. Why particularly the lower income?
Yes. It's high prevalence in Africa and in lower income countries. Yeah, and in low, even in the same country, in the low socioeconomic status, is related to inability to access the cervix, mainly inability to access the cervix. For example, if we have low socioeconomic status who are vaccinated, or screened, then they will escape having the cervical cancer. It is only a matter of facilities, availability, accessibility of this, because it is totally prevented. That's what we need to insist on the policymakers and on the stakeholders, on the population, that this disease is totally preventable. And the actions, if done, there will not be any cervical cancer if you can pick the pre-invasive stage and treat that one. Another thing is that it is also related to multiparity.
What we are going to do, what did you
Because
tell
the
me?
cervix is by repeated delivery, the
Only came and
cervix
told me
is
that you wanted money to buy it.
Martha,
saturated, and the
Sorry.
infection is having more chance of being persistent. And if the women started getting pregnant and delivery very early on the teenager, if she had multiple pregnancies, then this will make the cervix more liable to persist the infection and not to be cured by the natural immunity. This is another cause also, but it is mainly due to lack of facilities.
Okay, thank you.
The UK.
Thank you. We have Victoria.
Thank you very much. First of all, maybe we can ask Klein to mute because there is some background noise from Klein. Klein, if you can mute. Thank you so much. And thank you so much, our presenter. Her explanations are really great. I also just want to add to the fact that the reason why the poor tend to be victims also, on top of maybe having children early, is also having their sexual debut. That is to mean they start to have sex early in their lives when they're still young and their bodies are not yet developed. And so the trauma to their bodies is the reason why also they're susceptible to developing cervical cancer. Thank you very much. I'm Victoria from Kenya. I did a study on cervical cancer and the challenges of communicating about the disease for my PhD thesis. Thank you.
Thank you very much.
There's a hand there, Sulafa. Can you see it?
Yeah, we have Karin also is raising hand.
Thank you. My name is Karen, SI Accra. I'd just like to make a comment on the screening, health screening, and the lack thereof. You see, health screening is a way of life. And we must admit that most Africans do not go to health facilities if they are not sick. So that is a blow to screening. And unless, perhaps we should try to encourage this as part of our campaign under the project, to encourage people, women, girls, boys, to go to health facilities for checkups, regular checkups. Thank you.
Thank you. Karin, you can lower down your hand, please. We have a comment on the chat about the Health for Life Fund. And
Plain want to
President,
sorry.
Sorry, President Jalila.
Yeah, thank you very much. I saw that Plain hand up her hand, so I just answered to Karen Corsa from Ghana. She asked about the Health for Life, the access to Health for Life. is critical to the project. Can SIAF provide some information and step-by-step guidelines on how to access funding? So the idea is that you present your project of actions to SIAF, and thereafter we will give you with the after scene with the Health for Life the grant to make your action. Is it correct, President Connie?
It's almost correct. Almost. Okay. So the agreement that we had with Health for Life is that we fundraise together and put that money in a pot, right? And out of that pot, we will get some administrative fees just to use around the continent for awareness, for advocacy. So that is the pot for Health for Life. We also were talking about having a project, like some pilot project, where we'll ask for you to submit your projects, and then from there we'll choose those projects, and then we'll fund them with Health for Life. But that's not there yet. President Jalila, you recall we had a meeting with those optimists. We raised some 16,000 US dollars when we were in Durban, when we sold those tables, and some clubs in Europe are holding their money. They want to send it to a bank where we will access that money. So and they want that money used for awareness. Correct, President Jalila? Yes, they want that money that is coming from fellow Soroptimis for us to do the groundwork, awareness, print some flyers in our local languages so that they actually reach the grassroots levels. So so when you ask about the Health for Life, yes, we are talking when they give us a green light to say we are ready to release money, then we will we'll ask you for projects. We'll call for projects. But what we need to do as Africa is have our program director in place so that this program director can really run with this project, because it's not a project for today only. It's a long-term project. In 10 years' time, we'll still be doing this project. So we have been given a few organizations that we are going to team up with Health for Life to send proposals for money, because what we want is not $16,000, it's not 20, but what we want are millions of dollars for this. So we'll start small, but we'll just go big if we find all they want is, when we get this money, all they want is accountability for the funding. What is it that you are doing? Have you done this? Have you done ABC? Continual reporting. So I think, President Jalila, have I left anything?
No, that's very good. Thank you, President Connie.
Okay.
And I just want to say to say again, as you said, this is a project for SIAF. It's a project for a long time. It's not project just for 1 or 2 years, or it's for a long time. So
because we want to eradicate cancer.
yes, this is the project is to
Okay.
eradicate. So this is what we are saying. It's for a long time. Thank you very much.
Back to you, Dr. Sulava.
Sorry, President Connie. Are you Connie?
No, I'm saying we are giving it back to you. I think Madison Chamberlain wrote something that I can't see. Perhaps you can see it there.
Yeah, she's asking, is there a format for submitting the project proposal? And I had answered that to her, it's not yet. Not yet. There is no.
Not yet. I think she's answered. Hi.
And we have also Plain. She hand up her hand before.
Yeah, I was just hello. Thank you very much for calling me. I think we're quite aware of the fact that there's more of ignorance even than availability. I say so because just before the charter of the Ndobo Club in Douala, we did a sensitization and awareness campaign. And I was so amazed that 150 women had never, ever heard of cervical cancer. They never knew about screening. They never knew about treatment. So as Connie said, we start from the base, the foundation, the bottom line. And it is to create awareness, most important, because immediately these 150 women asked where they could go for screening because they understood. A good campaign, a good sensitization and awareness will make the women go for screening. So that is where our strength lies, getting the African woman to know that there's this disease and that it can be treated. Thank you very much. That's just an input I wanted to give you.
Thank you so much. Yes, you are absolutely right. Awareness is a cornerstone for the success of elimination of cervical cancer.
Dr. Sulafa, we have with us Madison Chamberlain. She's from New Zealand, so we are very happy to welcome her with us here in Africa. Thank you, Madison. Can you introduce yourself?
Hi, I am Maddie. I'm from New Zealand. As you can see, the sun's coming in. It's Saturday morning here.
Yeah, I know.
I'm very interested to see this project in New Zealand here. We're doing stuff for ovarian cancer. So very interested in this space and cool to see what's happening.
Thank you. Thank you.
I'm sorry to come in again. Are there any Optimist members in Dubai, from Dubai in the meeting?
No, we didn't invite them.
No, but Renata, sorry, President, sorry, IPP Connie. Renata, normally she told me that she will join, so maybe she had something she couldn't, but normally she said that she will join the meeting.
Is she from Dubai?
She's the current president of the club.
Oh, the president, we met here.
I need a contact. I'm in Dubai now. I'd like to meet them, please.
I will send you her contact.
All right. Thank you very much. Yes.
Or Linda's.
Or Linda's contact, yeah.
Okay. Thank you.
Hello, Dr. Sulafa. I can have the floor briefly.
Hello.
Yes, this is Mary. I'm calling from Nairobi. Good evening, sisters. I think the presentation was very informative and it was very good to hear the progress and the steps and the structure of how to identify a case and how to treat it. Thank you so much to Dr. Amira for this awareness. I just wanted to give input that there exists a lot of work by our governments and the ministries of health. And because this is a WHO target and WHO undertaking, every country Ministry of Health already has these targets, and local clubs can easily understand what to do by going to check with the current officials of Ministries of Health, because the awareness program is so important for both parents and also for schools. And I know already our club actions target girls that are in school, and we need to see how can we integrate existing projects by club actions to also include this. For example, my organization that I work on, we work very much on sexual reproductive health rights and HIV/AIDS prevention. And our funding includes sensitization and awareness for cervical cancer elimination, and also availing the vaccination to adolescent girls and young women aged 10 to 24, because we know this is the group that is highly likely to be affected by HIV. And if you have HIV, again, you become highly likely that cervical cancer will be a problem for you. So we need to check well with the Ministries of Health and formulate little actions that we can do. We don't have to do too much as clubs or as countries or as networks, but we can come together and agree how will our awareness campaign begin and what can we make it as a proposal, so that when we get funding or we get other action-oriented activities, we integrate the raising of awareness for cervical cancer screening, treatment, and all this that we are learning in the webinar. So thank you so much, Jalila, for this webinar. I agree with you. It should be done again and again, and even at club level. This is very good information. Thank you, and back to you, Dr. Sulafa.
Thank you, Moy, for your input. Yeah, but I think that here in Africa, not all of the countries have cervical cancer as a priority, and it is not as a national plan at the Federal Ministry of Health. So yes, I agree with you that we as seroptomists, really, this is a unique opportunity for us to have a uniform way of working in different countries. And for example, as the queen of beauty, we see is the young girls when one is nominated to be the queen. On the second or the third day, you find all of the media, they agreed and they shared this. So I think if we have a good plan, then we can reach all levels of educated, non-educated, different age groups. We have the social media now; it can help us a lot, and that for all of us in seroptomists in Africa, I think this will make our process is more easier to reach people in different countries. Professor Ahmed, he's raising his hand.
Thank you very much. Thank you. First of all, thank you for the invitation. We got this invitation. Me and Sulafa were in the same university, and we got this invitation through her in our university WhatsApp chat group. And my regards to Amira, who was 2 or is it 3 years behind us in medical school. So thank you for a very nice lecture. What I'm saying now, I'm the director of a health research center in our university, and although I am in a different specialty, I do quite a lot of work in maternal and child health. I'm a cardiothoracic surgeon, but currently we're working in maternal and child health in Ghana. Well, we are just applied for a grant in Ghana, and we also have some ongoing work in Zambia. We used to have some work in Sudan, but unfortunately, with the current situation, that has stopped. What I'm saying is that for awareness raising, I think you should widen your net. There's a lot of, I'm surprised by the way, by the figures that you've shown us, 321 dying every day. That's a huge number. We got a lot of funding in my specialty, cardiothoracic, to work against rheumatic heart disease. We got, over the last 10 years, we have got something like $10 million to do something like, we now publish more than 50 papers in rheumatic heart disease. And that is just, we were very persistent. Now, the money in maternal and child health is much, much more than what we can get. That's why me, as a director of a research center, I've gone to that. For example, in Ghana now, we're raising awareness amongst pregnant women along their life course. But to tell you the truth, there is no visibility for cervical cancer. Cervical cancer for us is not even in our agenda at all. So what I'm saying is that you should think out of the box. You should look at raising awareness by, for example, me also, I target HIV funding quite a lot, see where I can get money from it to use in my cardiothoracic. And there's a lot of things that we can do and we're doing already. But my suggestion for you, the low-hanging fruit, is maternal and child health care funding. We're working on a project now with Sulafa. That is, we're funding it through my research center for awareness in cervical cancer. And we hope once we've established our pilot here, we will be able to, we've done our preliminary pilot, we'll hopefully share that with you. And again, you know, breast cancer, for example, that's another area I work in. There's a lot of funding in that is very easily accessible. In fact, I think the NIH now has a couple of grants coming out for breast cancer. So I think you should tap into that also. And thank you very much. And thank you, Amira, for what was a very nice lecture.
Thank you, Prof. Ahmed, for your advice. And we will be in touch with you, and we will consult you as a theraptomist. And fortunately, now he's available in Cairo, so we can ask you to give some of your time to us.
Gladly.
Thank you very much, Professor.
Any comment? Yeah, thank you.
Can we invite his, it's a year, right, Professor?
Yes.
My connection was unstable.
Yes, okay. Can we invite his wife to become a soroptimist? So that we always keep.
Is a very good suggestion, President Connie.
That is lovely, President Connie.
Okay.
That's good. That's good. I stopped myself to say that.
You did. So he's always closer when we need him.
Hello.
Yes,
thank you
Maka.
very much. Thank you, President Jalila. Thank you, immediate past President Connie. Thank you very much, Dr. Sulafa, Dr. Amira. It's a wonderful contributions. It has been informative, it has been educative, and we've learned a lot. We are going back home to go on the drawing board to see how we can apply all this knowledge. It's very practicable. And it was my pleasure to be on this forum today to listen to all the experts talk about the experience and what is available. Awareness, awareness, awareness. And I know it's feasible. Thank you. Back to you, Jalila.
Yes, here I am. Yeah, thank you, Marta. I think we didn't hear what you said on the last part of your input.
No, yeah, can I come back? Are you getting me? Yeah, what I was saying is that after listening to everybody talk, I believe that cancer can be eradicated in Africa because all the information and the knowledge that we have received so far, we can apply it, and I know we can do it. It is doable, it is feasible, and we can do it, especially working with our governments, because we have these programs with our governments in our countries, especially in Cameroon, and we can always work in partnership with our government. So I'm so happy for this information, and I've gained a lot, and I think we can do our best to eradicate cancer in Africa, cervical cancer in Africa. Thank you.
Yes. Thank you.
I'm through. Did you get me? It's
Yes,
like you
we
didn't hear
did.
what I was saying.
No, we did. We just didn't clap our hands.
Absolutely.
I just want to
Well
assure
done.
you that it's doable. And then
Yes.
the lectures we've received is quite educative, it's informative, it's quite applicable
Yes.
and feasible. Yes.
Yes.
It's good to
This
share.
is
We have shared, and sometimes we were like worried. How do we go about it? But now, like I was saying, we can always do it in so many dimensions. In my country, we have programs like that with the government, with the state, and we'll do so well, and we'll do everything to make sure that we work in partnership with other organizations who are into this fight against cervical cancer in Africa. So I want to thank you all for your inputs. It was so valuable. Thank you, ladies. Thank you,
Thank
Dr.
you.
Amira.
Thank
Yes.
you. You are absolutely right. It is doable. It can be done. It was tried and it succeeds and it
Yeah.
works in other countries. So it can be done. Definitely.
We have just I think the problem will be to convince people to vaccine. I don't know what is the situation in your respective countries, but in my country, Morocco, it's there is people don't want to hear about vaccination, you know. So and moreover for children, for young girl. So it's a little bit sensitive, but there is, as you said, there is a government program for fighting cervical cancer with the awareness and screening, but it's there is no campaign, if you want to say, not a real campaign. So that's just about vaccination. It's from the 2020 with the COVID pandemic. So people didn't want to hear about vaccination.
Yeah. Victoria is raising her hand. If you finish, President Jalila.
Yeah.
Yeah. Thank you, President Jalila. That issue of vaccination is really big in Africa. We have culture, we have religion, and those, especially culture and religion, are very, they come in the way of vaccination because they are myths, some unsubstantiated, unproven claims about what the HPV vaccination is all about. So it is for us, seroptimists who are educated, who are aware, who are knowledgeable, to use our clubs and the campaigns that we can organize to let our communities understand that it is okay to go for the vaccination. When I go home to my village and I talk to the women, they believe me because they brought me up, they took me to school. So if I tell them it is okay for our daughters to be vaccinated, they will believe me. So that is why seroptimists in their small groups are the best to go to the grassroots levels to ensure that the campaign, the awareness about the HPV vaccination is, and also plus the screening processes are done. Otherwise, we can talk up there, the big medical people can talk about it, but they need people like you and me who grew up or who understand the language to talk to them. And they will say, oh, this is our daughter, and she can't mean bad for us. So it is, we have to break down, we have to debunk the myths, we have to demystify all those issues. That is what happens with all other vaccination campaigns. Thank you.
Thank you, Victoria. Thank you so much. Any more suggestions, questions, or?
Excuse me, Sulafa, maybe can we have countries that the people write in messages in discussion which country they are from, so then we can put it in our report that we had 10 countries or something like that. So we know Madison where she's from. We know Victoria, you and Amira, Connie and me, Marta from Cameroon, Marie Muya from Kenya. So let us.
Prof. Ahmed from Sudan.
Okay. Caroline Yembe from Yaoundé. Okay. That's to
Also,
know.
Dalia from Sudan.
Okay.
I think your suggestion was absolutely right, that on the chat, please, participants, write your country in the chat.
Yeah. Kenya, so. Donc, on a le Cameroun, Kenya, Sudan, New Zealand, Sudan, Zimbabwe,
Ghana.
Ghana. So, Morocco. Till now, 7 countries. Sudan, 7 countries. Yeah.
Yazihur, you're welcome. You can add your suggestion.
Hello all. I'm so glad that I joined this webinar. And it's my honor to be attending it today. I'm Al-Zuhur Al-Mahdi. I'm a general practitioner in Sudan, and I'm a research assistant at Cervical Cancer Prevention and Control Unit in Soba University Hospital. I would like to add some suggestions that may change the future for the next generation regarding cervical cancer. Since I work during my college life, I worked with different organizations, different peers, many profit and non-profit organizations, and I get in contact with the community in different ways. So I would like to suggest networking with community-based organization. This what makes the big difference in translating the message of the importance of getting vaccine or doing screening, especially in the taboo issues that, for example, cervical cancer and other medical issues that is okay, it's a forbidden, or it has a taboo, or it has a stigma in our community. So so networking is one of the important things that we have to look for in terms of community-based organization and in terms of national or international organizations. Also, I was during my school life, I worked with, as a manager for the Office of Reproductive Health and Reproductive Health and AIDS Prevention. We were targeting beers, so we developed a beer education toolkit, which help us a lot in the community awareness and community mobilization toward like raising their awareness of the reproductive health issues in general. Also, I want to add the theater role. Theater role has a powerful agent in delivering the message to the community. So yeah, we have to like take those into consideration. Yeah. Thank you very much.
Thank you.
Thank you. Yeah, thank you. Thank you, Zuhur.
Thank you, Zuhur. How are you?
How are you doing? I miss you all. Thank you very much. I used to work with Dr. Amira in the cervical cancer and prevention unit, and I attend the International Papilloma Virus Conference in the United States. So the updates are amazing. The updates like the developed countries are way like they develop mechanisms that enable them to reach out to the community in a simpler way, in a precise way that could make a big and a positive like change. Yeah.
Thank you, Zuhur. And we are waiting for your input. Next time we must have an activity in January because it's a month of cervical cancer. And now President Jalila is raising her hand.
Yeah, thank you very much, Dr. Sulafa. Just I think it's we will close the webinar. I would like to thank again Dr. Amira Burhan for this very interesting presentation. Thank you very much, and sorry for the short time we gave you to prepare it. We would like to have this such a webinar another time, because we need to aware all Soroptimist sister. You know, I worked those days on this topic, and I met a doctor, an oncologist, and she talked a little, and she asked me, have you ever be screened for cervical cancer? And I was so confused, and so I told her, never, that's true. So now it's going in my mind, and I have to do it. yeah, I have to do that very, very soon. So really, I was shocked when she asked me, but she's right. We are not aware about that. So those webinars are very, very important too. As you said in your presentation, we can't make awareness to other people if we are not aware by ourselves. So this is very important, and thank you very much again for all the information that you gave us to this evening. Thank you also, Dr. Zulafa, for moderating the webinar. It's very, very an exercise. It's not such easy exercise. And I would like to thank all the attendees for this, for giving the time to stay with us. And we hope to meet again very soon.
Yeah.
Let you finish, Dr. Zulafa. Thank you very much.
Okay.
Thank you very much. Thank you very much
Thank
for
you.
giving me this chance, and thank you for your time. Bye.
Thank you, ladies. Thank you for your inputs, valuable inputs.
Yeah.
Thank you.
Thank you. We do appreciate. Thanks so much.
Okay, thank you. Bye.
Prof. Ahmed, I cannot wait to speak about. For me, it's a surprise for my sister in Seroptomist. Really, I'm working with Prof. Ahmed. He giving me a chance to work in a very nice project regarding cervical cancer. And once we reach at a stage that I can let you know it, or when we succeeded, I will share it with you immediately. Thank you so much, Prof. Ahmed, for your efforts in helping us. And we are waiting for more.
Well, thank you. Thank you very much. And it's a pleasure to be with you, and I hope we can do something together. Thank you.
Thank you.
Okay,
Dr.
then.
Zulafa, I met Dr. Sarah 2 days ago here in Nairobi, your club member. She is visiting and
Mary.
having a meeting in Nairobi. Yes.
Yeah, Dr. Sarah Lavinia, you met her. Yeah.
Yes,
It's
I
a
have
very
tea
nice.
coffee with her. Yes, on Tuesday. Very nice. Yes, we speak a lot about partnerships.
Okay.
Yes, on this subject. Yeah, good. Okay. Good night, ladies.
Yeah.
Good night.
And our
Yeah,
sister
good night.
in
Good
Australia,
night.
good day. She is on Saturday already.
Good night.
Okay. Bye.
Bye.
Good night.